Mhm. Start in 10 minutes. Everyone comes at the last minute. Yeah, you want to come in, Ibrahim? Let me see here. Let me get organized. Yes, okay, you can talk now, Ibrahim. Ibra.
Hey, John,
Hey, how
how
you
are you?
doing? You want to get
I'm
promoted? You want to come in the webcast?
sure.
How you been?
I'm good. How about you?
Good. I'm glad to see you here.
Yes, how are you?
Good. We've been very busy. We have another webcast after this with
Oh, really?
yeah, with a neurosurgeon from San Francisco, John Adler.
Oh, okay.
Yeah,
That's
you're
great.
welcome to come to that.
Okay, all right.
Yeah, let me show you. Let me share the screen and show you.
Okay. That will be great. How is the family?
Good,
Okay.
good. They're leaving me alone to work, which is great.
Yeah, you're actually doing great work all time because
Well,
people are
I
always
have
just
fun.
under.
Believe me, it would be difficult, but what this is to me, it's fun.
Yes, it is. Definitely it is fun.
Okay, here is the one we have. Okay, that's today. Now we have one here, John Adler from Stanford. He's going to talk about radiosurgery, which
Oh,
is
that's nice.
there's kind of a weak point in education. There's not much radiosurgery online, and he's going to talk about this. It's not relative. It's about 10 years old, I think,
Oh,
but
that's great.
apparently it's getting a little more popular, and he's going to talk about that. He's the one that invented the cyber knife.
Oh, that's
Oh,
great.
yeah, also.
Mm,
So he's got his hand in two areas.
wow,
You
that's great.
see, yeah, yeah, yeah.
So that is going to be happening after this one?
That's this is 8 o'clock. It's at 10:30. It's like about an hour after done.
All right, that's great. Let
Where
me see.
you're in Guinea, right? You're in
Yes. I'm actually back in my country. I'm actually in Guinea. Yes.
okay.
Yeah, since like almost 6 months.
Can you share your screen and show me once again?
All right, let me see. I want to
And
see
can
if
you?
I
You're
can.
on a smartphone, right?
Yes, I want to use my computer now because it's
Okay.
more clear here.
I know it's difficult to share a screen in the smartphone.
Okay, let me see. Okay. All right. I think you wanted me to share the screen you can see, if possible.
Not yet. I've got
Okay.
to become more adept at the smartphone because I don't think I even know how to share a screen.
Let's see. I think it's possible for me. Yes. I think it's possible, all right? You can see the screen.
Not yet.
Hmm.
Okay, yeah, we can see it now.
Yes.
Now the screen is yours. Take us where you want to take us.
Today is Professor James Leo
James
having
Leo, correct,
right?
correct. Yes.
Okay, that's great. I actually haven't been back, and I was trying to see how we can able also to start something from this side. I know your schedule is quite busy.
You know, there's a way you can put the icon for Neurosurgical TV on your desktop.
Okay,
You know how to make a shortcut to the website, right?
all right,
Yeah.
all right.
Well, you can do
That
that later, but
okay, we're gonna have that. I still have your WeChat. I don't know, sometimes still using it, right?
I don't know. The app is not functional.
Okay,
You
then
really gotta keep on
I will
top of
send
that,
you
and I really
instead of
don't have the
WhatsApp
time.
is better, right?
Yeah, you're off to screen share now. Yeah,
Okay.
once you stay off
I
here.
mean, your WhatsApp is still
Now,
working.
you watch, Abraham, there's gonna be a rush. Oh, this our shot. Oh, good.
Sure. All right. So this one is going to begin like few minutes, right?
Yeah, in about 10 minutes.
Okay. All right. That's great. All right. So I
Harshad,
want,
how you doing? Have you met Harshad before?
sorry?
Hi, John.
How you doing?
Hi, John. I'm fine. How are you?
Good. Muhammad Helmi is going to host. Actually, Ben asked him to, okay? Okay, Harshad?
Yes. It's been joining.
Ben's in Istanbul, apparently.
Okay, okay.
He's at a conference there, I believe. Muhammad could probably tell me. So how you been, Harshad?
John, I'm fine. Okay, going on. Nothing great.
Oh, you're in the hospital now?
No, no. Today is Sunday evening at home.
Oh, okay.
Yeah,
Sunday evening, that's right. About
Yeah.
5 o'clock, 6 o'clock, right?
yeah. 5:30 in the evening.
Good day, Muhammad. Are you there?
Hello, John. Can you hear me?
Yes.
Yeah, I'm here.
Now,
Hello, Professor Harshad. Hi, Ibrahim.
well, you know
Hello,
what,
Mohammed. Hello, Mohammed.
Muhammad, you won't believe what happened. I was
Yeah.
thinking of inviting you here just to be
Mhm.
here. And I was looking for it. I couldn't find it. How many M's in Muhammad and everything else. And then I get something from Ben that says, "Oh, Muhammad's going to host." I said, "Man, I couldn't believe that." That was, and I chatted with Samuel O'Morsi, who
Yeah.
apparently he worked with. I said, "Do you
Mhm.
know Muhammad's?" And he gave me your what's up.
Yeah. I think I changed that WhatsApp.
Yeah, yeah. He
I'll
knew
send
right. He
you.
knew right away. Yeah,
I'll
I
send.
guess you guys worked in the getting something ready, ECMFG tests or whatever.
For a long time, I think.
That was a while ago.
Yeah, I sent you the new WhatsApp number.
Oh, okay. Yeah, that's right. It said your old one was no longer good.
Yeah.
Let's see here.
I can see Dr. Ibrahim is here. Long time no see, bro. Oh, Professor James Leo, I think he's in the attendee. Could you bring
Oh, there
him?
he is.
Yeah.
I'll make you a co-panelist, Muhammad.
Good morning.
Good
Yeah, good morning.
morning.
Hello.
How you doing, James?
Hi.
Hello. Good. How are you? Long time no.
Good. David.
Good morning, James.
Good morning. How are you?
I'm good. Great to see you again.
Yeah, good to see you. It's been a long time.
Yes, yes. Quite some time we are missing.
Good morning, Professor James.
Good morning. Hi, how are you?
James, how you doing?
Good. How about you?
Well, doing well.
Okay, Ibrahim is from
Guinea.
Guinea, Africa.
Yes. Mohammed, how are you?
All good, Brahim. How are you doing?
Yeah, I'm doing great. How about you?
People will come
All
and
good.
they come late, James.
Okay,
Great to see you
I'll be
again.
So
back in just a second.
Bye.
I have to grab something.
yeah, no hurry, James. So Mohammed, how you been?
All good, alhamdulillah. Now I'm working here in Shanghai.
You're in Shanghai.
Yeah.
That's one of Bin's hospitals, right?
No,
No,
actually, it's not a private hospital. It's not Huashan Hospital. I'm working in private hospital.
no, it's a huge hospital, right?
Yeah, yes.
How many neurosurgeons do you have?
In our hospital, we have 16 because our hospital is specialized hospital in neurosurgery and neurology. So we are a specialized private hospital in Shanghai. I think we are the biggest here in Shanghai. And we also work with Professor Bin Shu. So sometimes we have some complicated surgeries where we need like his bypass technique. So we ask him to come.
Do they combine the departments of neurology and neurosurgery?
Our hospital mainly about the neurological and the neurosurgical diseases. It's a specialized private hospital.
Okay.
And
How
it
much?
was by
How many beds?
we have now 200 and we opened a new award last week. So now we have 235, I think. And 2 awards is VIP one.
So how many OR?
We have 7 and 7 for craniotomies and 2 for the interventional surgery.
Okay. And how many neurosurgeons are working as a consultant?
16. We have 6 consultant, like chief because we are, in China they have as in other countries we have the subspecialization is like it's not like general neurosurgery. We have a neurosurgeon mainly for brain tumors. We have neurosurgeon mainly working for cerebrovascular, as the case with Professor Bin Shu, like this. So we have 4 neurosurgical sub teams, we can say. Yeah. And we have 6 consultant and 10 like specialist, or we can say resident.
James, do you want to start now, or people will come in as we go along?
Yeah, sure, that's fine.
Yeah, because you got a busy schedule, right?
Yeah,
Today,
no
probably.
problem.
Personal day. That's your schedule today.
Do you have a YouTube live link for this?
Yeah, it's on my channel. It's on the Neurosurgical TV channel.
Okay, terrific.
Okay, I'll put it in the text. Yeah, it's connected to the website. There's a link to it from the website. Okay, let's start. 10, 9, 8, 7. So let me make sure I got. Oh, okay. 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from sunny Miami Beach, Neurosurgical TV. It's still dark here. We have the second, the bi-monthly Chinese Neurosurgical Journal webcast with a repeat guest, James Leo. And I was fortunate enough to finally run into Mohammed Helmi. He's going to moderate because Ben is in Istanbul at a conference. It's all yours, Mohammed.
Thank you, John. So hello everyone, welcome again for the bi-monthly webcast, the episode of the China Neurosurgical Journal webcast. So today we have 2 eminent speakers, and we will start with the first presentation of Professor James Liu. I think we don't need to introduce him. I think everyone knows his name. And the first interesting topic is talking about the journey to the center of the brain, the routes less traveled. I think this is a very interesting topic, and it will be more interested to heard by us from Professor James Leo. So please start.
Great. Thank you for that kind introduction. Allow me to share my screen. Okay, can everyone see my screen?
Yes.
Okay, terrific. Sorry, John, I lost my screen here for a second.
That's all right.
Let me redo this here. Okay, can you see my screen?
Yes, perfect.
Okay, terrific. All right, well, thank you for that kind of introduction. Today I want to talk about the journey to the center of the brain. And this has been a long fascination for me, and it's sort of what inspired me to go into neurosurgery, particularly skull-based surgery. But I want to talk about some interesting routes and corridors that we generally don't necessarily talk about. We know that the routes to the deep-seated regions of the brain, and I mostly talk about skull-based approaches, whether it's an open skull-based approach or an endoscopic endonasal expanded approach. But there are other routes to deep parts of the brain as well, and I want to focus on the deep ventricular systems of the brain and also the tentorial and the falcine regions of the brain. And these are interesting lesions that occur here, and there often can be difficult, and you're met with a lot of critical structures, particularly within the third ventricle. You can see you have the internal cerebral veins, you have the fornices, which are involved with the memory function, and you have the pineal gland, and then the brainstem as well. And so this is a cartoon from Roten's Atlas. You could see all the different approaches to get to the ventricular system, and some of these go through the brain cortex, and some of these go through the natural fissures and corridors of the brain. And I like to focus on the fissures because these are natural corridors to get into deep parts of the brain. And the major advantage of interhemispheric approaches through these fissures is that you don't violate the brain matter or the brain cortex. And I think there's a huge advantage to that. And the question is, how do you get down into the deep corridors without injuring the brain? And I often think about these mountaineers who climb through these deep crevasses to get into these deep corridors, and to get into these lesions. It's much like that. So let's start with the lateral ventricular system. This is a gentleman who had this large tumor. You can see it's heterogeneous, very classic appearance of a central neurocytoma. These tumors are benign tumors, but they can look rather ominous. They often grow from the septum pellucidum, and they can cause obstructive hydrocephalus. So different routes you can take. You can go through a transcortical corridor, go through the brain cortex and get to the tumor. The major disadvantage is that often you can have a blind spot from your line of sight. And I've seen several cases where people have left residual tumor because it's often difficult to look into that upper corner. Alternatively, you can do a transcallosal approach, interhemispheric, which we did here. And here you can get equal access to both ventricular systems. And so we do this in the lateral position. It's very important to position the head so that the angle of the falx is roughly about 20 to 30 degrees from the horizontal, from the floor, the plane of the floor. We do a linear incision, and when I do the bone flap, I tailor the bone flap so it crosses the midline. And this is important because you have to be able to retract the superior sagittal sinus by a few millimeters when you retract the dura. And this gives you that extra few millimeters that really makes a huge advantage and so forth. So here we've positioned the patient left side up. The reason why is that the tumor, to me, appears more on the left, and by gravity, I can have the left side fall down into the field. And so we'll position the left side up. Here's the video showing this surgery. Here we've placed a ventricular drain intraoperatively, and this will allow us to relax the ventricular system to get into this inner hemispheric fissure. Doing the lateral position, the brain naturally falls away from the falx, and you can have a nice retractorless dissection through the interhemispheric fissure, identifying the callosal marginal. And don't be fooled by the callosal marginals. You want to make sure you see the white color of the corpus callosum to confirm your pericallosal arteries. After you mobilize the pericallosal arteries, we'll do a callosotomy using image guidance to help guide us. And immediately we enter the tumor because the tumor is right underneath the corpus callosum. Once you gain control of the anterior pole of the tumor, you can see the ependema of the ventricle system. And here we're separating the tumor carefully from the floor of the lateral ventricle. And this is crucial because we want to identify where the fornices are. And the choroid plexus helps us guide us where these structures are. But you have to be very careful in dissecting it away from the fornix, which we did here. And here I'm just inspecting the fornices. They're intact. You have choroid plexus here, and we have a view of the third ventricle. This tumor dissected itself into the third ventricle, and you can see the third ventricular system here is intact. I'll often use an endoscope, and you can see the spectacular view of the atrium, looking posteriorly into the atrium. And then here's the basal ganglia. This is where the tumors often can invade into the floor of the lateral ventricle. And using cautery, we can carefully dissect this away. And this patient had a terrific result, complete removal. He did eventually need a shunt for persistent hydrocephalus, but he's back to work and maintains a normal life. This is 2 years post-op, recurrence-free. You can see after shunting, the ventricular system comes back to same size. What about access to the third ventricle? This is a little bit deeper into the ventricular system and can be a little bit more challenging. There's different routes to get to the third ventricle. I'd like to break up the third ventricle into anterior third ventricle and posterior third ventricle. But anterior third ventricle, again, we can use the transcallosal approach through the interhemispheric approach. But then to get into the third ventricle, you have different options. So you can go through the foramen Monro. This is transforaminal. You can go through the choroidal fissure through a subchoroidal or suprachoroidal approach, or you can go right in between the leaflets of the septum pellucidum and then separate the fornices to do an interforniceal approach. Now, there's different advantages of doing each of these. Most people around the world are doing transforaminal or transchoroidal. And the road that is less traveled is this interforniceal approach. And the reason why is because there is a higher risk when you go interforniceal in that you have a chance of injuring both fornices, and that can result in severe cognitive impairment and memory loss. But there is a huge advantage if you're able to master this approach and avoid forniceal injury. You have a beautiful midline view. And you have access to both walls of the third ventricle. So here's the transforaminal route going through a foramen Monro, and you need a large foramen of Monro to be able to do this, and you can open up this corridor by dividing the choroidal fissure to expand that approach. Here's the transchoroidal variant going through the telechoroidea. And then here's the interforniceal approach. and you get this beautiful view of a strictly midline view, go in between the intercerebral veins and so forth. And this is Roten's illustrator who's illustrated this, showing a retractor approach. And you have to be careful when you're retracting the fornices. This is where I believe the approach has largely been abandoned. But over the last 17 years of my experience, I've explored the interforniceal approach, and I think we can do this in a safe manner, in an effective manner as well. And so, how can we avoid injury to the fornices? And I'm going to show you some operative tricks and nuances to do that. This is an example of a more common anterior third ventricular lesion called a colloid cyst. And you could see this is one that we've done through an anterior interforniceal approach. So this is a patient who was shunted at another hospital because they didn't feel comfortable doing this through a surgical approach. And when you've lost the ventricular size, it's hard to do a transcortical approach. This would be very hard to do endoscopically. And mere drainage is an incomplete treatment, as these often recur if you just drain it. So here we've opened up the lateral ventricular system. There's the shunt catheter from the previous surgery. And oftentimes these lesions don't really present itself that well to the foramen Monro. Here we're seeing the tumor, we're separating it through the interforniceal. Now we're actually dividing the interforniceal plane, and there is the tumor, or the colloid cyst rather, and we're slowly draining portions of it. We're not draining all of it. We want to keep the mucoid material within the cyst as long as possible. It maintains the turgor of the cyst, and we've come around the posterior margin of it. And as we dissect around the cyst, it slowly decompresses itself because we made a small opening in the cyst. And then we carefully use these microbanded forceps to carefully dissect around all of the critical structures. And in the lateral position, we're not really retracting on the brain or on the fornices. This is a retractorless approach. And as we get completely around the cyst, there's always a few vascular adhesions, namely from the posterior medial choroidal vessels. And once you've determined that the cyst is entirely free of any attachments, we can now carefully deliver the colloid cyst. And this is one of the larger colloid cysts I've treated. You can see it's a massive lesion, close to 3 centimeters. And now we'll inspect. Here's the floor of the third ventricle. See how wide the foramen Monro is? There's the basilar artery nicely exposed. And then we're inspecting both fornices, which are nicely kept intact. You can see they've been understretched by this lesion. And there's the floor of the third ventricle, nicely intact. And this is the post-op MRI, a complete resection. And she's been recurrence-free now for over 10 years. And her memory was intact, and she was able to go back to work. This is a interesting lesion. This is a 52-year-old male, 3 days of headache. There's 2 signal changes here. You can see there's a bright signal in the third ventricle, and then there's another lesion here in the lateral ventricle. I wasn't sure if this was a colloid cyst that ruptured into the lateral ventricle, or maybe these are collision tumors, 2 separate tumors, and we'll find out here in the video. Here's the lateral position. You can see here's exposure of the pericallosal arteries in the lateral position, finding a safe zone in the corpus callosum, opening the corpus callosum. And you can see this is a rather avascular tumor, gray appearing. This ended up to be a subependymoma in the lateral ventricle. And subependymomas are nice tumors to remove. They're not very vascular. They're benign tumors, but they can grow and obstruct the ventricular system. So here we're using a scissors peeling technique where I'm just using the tips of the scissors to peel these arachnoid adhesions from the septum pellucidum. And now I'm down at the foramen Monro. And this is where you have to be very careful. I'm carefully just peeling the tumor from the fornix. And then once it's free, you can see there's the other side of the fornix. And by using sharp dissection is the key maneuver here. I don't use a blunt Roten number 6 dissector. Learn to use your scissors. You can see you can be very efficient with one tool, the scissors. The scissors is like a surgical machete. And you can see how just with one tool, you become very efficient. You cut, you peel, you dissect, and you deliver. And there it is. Voila. There's the foramen Monro. Now we have another lesion to go after. We're now going to open up the interforniceal corridor. I do it by finding the septum pellucidum, finding the natural plane between the two septum, and there's the internal cerebral veins. Now I have control over the top of the colloid cyst. Now, if I tried to deliver this through purely the transforaminal corridor, you could see how the tumor, the cyst goes upwards, and it doesn't present itself to the foramen Monro, and all of the adhesions are at the roof of the third ventricle. So I really believe that the interforniceal approach gives you a huge advantage. You get control of the roof of the third ventricle, and then I've pushed the third ventricular lesion down into the foramen Monro. So now I can deliver it through the foraminal corridor. So I'm actually using both combined interforniceal and transforaminal corridors, carefully dissecting the cyst away now that I've controlled the top of it. And these are almost always adherent to the choroid plexus. And so the advantage of doing an open approach as opposed to endoscopic is that you can dissect these adhesions. There's often a small vessel and perforator from the choroid plexus going into the cyst that's adherent to the cyst, and you can carefully coagulate and divide sharply. The endoscopic approach doesn't give you this advantage. You're using a suction device to remove these, and it often results in incomplete removal. And sometimes I feel is underreported is forniceal injury. And here is complete removal. The fornices are intact. Patient's memory is intact, and he went on to go back to work and maintain a normal life. So this was an interesting dual lesion. I want to show you this lesion. This is a midbrain lesion. This is a lesion that's arising from the mesencephalon. And this was a gentleman who had multiple ruptures of this mesencephalic cavernous malformation of the brainstem. He had a left third nerve palsy, diplopia, and it left him with some contralateral weakness on the right side. Now, how do we think about surgical approaches for a lesion like this? And there's a lot of ways to think about it. I considered, if you look on the slide to the right, I considered a lateral supracerebellar infratentorial approach. Very popular approach for these types of cavernomas. Disadvantage here would be that there's a rim of neural tissue that you would have to go through to get to it, which can pose some risks. And then the contralateral approach from the front would be a orbitozygomatic transsylvian approach. And again, you would have to get through some neural tissue to access this. But not only that, there's a lot of perforators coming from the basilar apex, which can be a bit risky. So when I thought about this, I looked at the coronal image. And if you look at the coronal image, there's a small portion of it that presents itself to the third ventricle. And I thought, through my experience using the interforniceal approach, we can easily see this wall. And if you come from the opposite side, you have a nice cross-court view of where the cavernoma presents itself. And so that is the approach I took. And you can see that approach ended up to be a great result. You can see complete removal of the cavernoma. It was hemorrhagic. It shelled itself very easily and didn't have to touch any surface of the brainstem. I did not have to violate any neural tissue. I just went through a natural opening that presented itself to the surface of the third ventricle. And here he is at 6 weeks post-op. So I talked about the anterior third ventricle. This is the posterior third ventricle. Different ways of getting there. You can get through the supracerebellar, occipital transtentorial, posterior interhemispheric, but also you can do this through an anterior hemispheric approach. And this is the one that I prefer if the lesion presents itself to the posterior third ventricle. If it gets way into the ventricular system, it's a little bit harder to come from the posterior approaches. This is the anatomy that you have to be aware of. When you put the anatomy on its side, and this is what I often do before a case, is that you want to be able to visualize these normal anatomy. And you're going to see the internal cerebral veins. And as you get posterior into the pineal region, remember that there's going to be a cerebral aqueduct. And then this is the posterior commissure, and there will be an arachnoid membrane back here investing the cistern posteriorly. And so this is the trajectory that we take to get to the posterior third ventricle. And of course, we have to work between the internal cerebral veins and be careful to preserve these to avoid a venous infarct. We'll do this again through an anterior frontal craniotomy that crosses the midline. Here's an example of one of these posterior third ventricular tumors I removed. This is the septum pellucidum. We go between the leaflets of the septum, divide and separate the fornices, and we find the first layer of the telochoroidea. And if you open up this arachnoid, go between the internal cerebral veins, you'll find the tumor. We'll take out the tumor, and you can see we've preserved the fornices, which have been splayed apart. There's the choroid plexus. And here's a paper we published not too long ago. This is a papillary tumor of the pineal region. These are benign tumors. And I'll show you here how we do this. This is the lateral approach. And again, separating the arachnoid of the interhemispheric fissure, finding the pericallosal arteries. There's the nice shiny white color of the corpus callosum. And then we'll separate the corpus callosum. Here we've fallen into one of the ventricles, the lateral ventricle. And then once you find one ventricle, you have to get control of the opposite ventricle. And then we'll separate the two leaflets of the septum pellucidum. And there's the natural cleavage and natural fissure between the leaflets of the septum. And you get down to the telochoroidea. Now I'm using these sponges. This is not gel foam. This is Bicol. Bicol is a nice substance in that it's not adherent, and it keeps the forniceal window open. So I don't have to use any retractors. This is one trick I do. And then once I open up the telochoroidea, I can see the tumor. And I'm going to start debulking the tumor, cauterizing it. And luckily, this tumor was soft and friable. And so I think firm fibrous tumors would be much more difficult to remove in this area. But luckily, this was a little bit softer. You can see there's some perforators here coming from the posterior medial choroidal arteries. And now that we gain control on the posterior margin of the tumor, we gain control on the anterior margin of the tumor, and we'll carefully divide the vascular feeders from these posterior medial choroidal vessels, and then remove the rest in a piecemeal fashion with ultrasonic aspiration, careful dissection of the tumor from the floor of the third ventricle, and then remove this in a piecemeal fashion. And so here's the final view. There's the third ventricle. And there's the cerebral aqueduct. There's the posterior commissure, and then the pineal recess. And then we inspect. Here's the choroid plexus. Both fornices are intact. And there's the final view. Here we're leaving a ventricular catheter in place. I no longer do this anymore, but this is what I did early on. As long as the field is dry, I don't leave a ventricular catheter. And here's the post-op scan. This is a recent case I did a few weeks ago. This was a large posterior third ventricular tumor. I chose an anterior transcallosal interforniceal approach for this rather than a posterior interhemispheric or supracerebellar. You can see that I felt that the distance would be shorter coming in from the front. And you can see here's the callosotomy. And this worked out beautifully. I got a complete removal of the tumor, and this ended up to be a metastatic lung carcinoma. And the patient did well, no memory loss issues. And I want to change gears. Let's talk about the falcotentorial region, particularly meningiomas. These are very challenging lesions to treat. These are all the different approaches we had talked about to get there. And when we talk about falcotentorial meningiomas, most of these can arise from the falx. Sometimes they're purely tentorial that grow into the falcotentorial region. Sometimes they grow in both falx and tentorium and can often invade the vein of Galen complex. And then some of these can be purely non-adherent to the tentorium. There's the velum interpositum meningiomas, which grow from the arachnoid cap cells, from the arachnoid of the velum interpositum, and there can be primary tumors in this region. But sometimes you can have recurrences of other tentorial meningiomas that have seeded the velum interpositum and then grow in the subarachnoid space in this area. So it's very important to know the venous anatomy, to know the position of the internal cerebral veins in the vein of Galen. Oftentimes this can help you determine your approach, but it's very important and critical to preserve those venous structures. This is a patient who had progressive growth of this falcotentorial meningioma. Here we've chosen an interhemispheric transfalcine approach. You can see you have to cut the falx to get to the opposite side. And here we've positioned the larger component of the tumor on the superior side. So we're going to position the right side up when we do a lateral position. Remember to angle the falx 30 degrees from horizontal. And we published this video in Neurosurgical Focus. Here we're showing the tumor exposure right along the falx. We find the tumor first at the falx. We can devascularize it from the falx, and we gain anterior control, finding the splenium of the corpus callosum, separating it from the corpus callosum. And now we're going to cut the falx to get to the opposite side. We're going to do a transfalcine exposure. And we can peel the tumor off of the corpus callosum, carefully separating it here. And there is the vein of Galen. So as you come around the backside of the tumor, always look for the vein of Galen. You want to preserve that. And now we're going to separate the tumor from the contralateral parietal lobe You can see we're separating it here. And it's a large tumor, so I often try to make the tumor smaller by debulking it. So you work with a smaller piece of tumor that you can roll and you can look around and inspect. The larger the tumor you're working with, the more likely you could torque and injure a hidden vessel. So I'm just trimming the tumor back to the falcotentorial junction. You can see there's the junction of the straight sinus and vein of Galen. It looks just like Rhoton's dissection. And so here I must stop. I felt that the tumor was invading the vein of Galen complex. I didn't want to injure it. And I often will use an endoscope to inspect. You could see the spectacular view of the contralateral parietal lobe and a near total removal here. Again, the key is to preserve those deep veins. If you don't preserve the deep veins, you can cause some serious injury, and you could treat the remnant, which we did here with stereotactic radiosurgery, and he had a beautiful outcome. Here's another example. This is a large falcotentorial meningioma, lady who presented with headaches. You could see supracerebellar would be limited here. The tumor goes way up. And when we study the venous system here, I did not see the vein of Galen or internal cerebral vein. Was it already occluded by the tumor? I wasn't sure. We'll find out during the surgery. I've since converted to a linear incision on some of these exposures if I need a larger craniotomy. These are easily healed. Here we put in a ventricular drain to help release the CSF. She had some hydrocephalus. And there's the tumor arising from the falx. You can see it's always quite vascular, and we can devascularize it nicely by getting early devascularization and control of the falx. I'll use a microdoppler to map out the straight sinus. It's easy to get lost when the falx becomes the tentorium. There's a slight curvature, and it's easy to get lost. So using image guidance and a microdoppler is very helpful. And so we'll open up the falx to get to the other side, start debulking the tumor with an ultrasonic aspirator. But here's the critical part. This is a dissection of the internal cerebral veins. The internal cerebral vein was actually invested in the capsule of the tumor, and most people would start to coagulate the capsule of the tumor. And if you had done that in this approach, you would have coagulated the internal cerebral veins. And so I was able to identify a microscopic remnant of the vein, and I was able to start dissecting it from the back of the tumor. You can see I'm leaving a cuff of tumor on the internal cerebral vein so I don't injure the internal cerebral vein. And this is how you can release the tumor from the venous structures. You trim along the vein, and if so, leave a little bit of tumor on the vein. It's better to leave a little bit of tumor on the vein than the vein on the tumor. And that's how you preserve the vein. You can see here's the internal cerebral vein. There's a microscopic layer of tumor on it. You can barely see it. This is the final view after delivery of the tumor. And you can see the vein, it was actually there the whole time. The vein was actually there the whole time. It was preserved, and you can see it re-expanding. And if you had coagulated the tumor capsule aggressively without first inspecting, you probably would have had a serious venous injury. So remember, preserve the deep veins. You can see radiographically, gross total, even though I knew I left microscopic tumor, she remains recurrence-free. This is her 2 weeks post-op. Beautiful clinical result. This is an example of another falcotentorial variant. This one is arising from the tentorium. So look at the origin of the tumor. It's in the tentorium, but it's growing in the supra and infratentorial space. Now, normally my rule is put the larger side of the tumor on the top, but this is the exception to the rule. If it's a tentorial origin of the meningioma, these tumors do not fall into the field from gravity because it's tethered to the tentorium, and it's not going to fall down. To visualize the opposite tentorium from a lateral approach is very difficult. So in this case, this is the exception to the rule. You put the larger side of the tumor on the dependent side. So we're going to go right side down. Hopefully that makes sense to you. You might have to watch the video to understand my thought process on that. But here you'll see, again, using the microdoppler to find, well, where the straight sinus is. We're going to first dissect the tumor from the falx towards the incisura, cauterize and devascularize the tumor, start debulking the tumor, and then we can start dissecting the tumor here. And then we're going to use cottonoid patties to separate the tumor. There's the splenium of the corpus callosum. This is the anterior pole of the tumor. Now we're separating the tumor from the falcotentorial junction. We're using the sonopet here to act as a scissors. And then we can now carefully release and dissect the tumor away. And here's the final view. Now, the vein of Galen was draped over the top of the tumor. So even though the vein of Galen is on the dorsal side of the tumor, you can still remove these tumors through the posterior interhemispheric approach. There's the trochlear nerve that we preserved. And that's the final view. Here's the post-op scan. You can see complete removal and neurologically intact. Here's another meningioma. This is a recurrent velum interpositum meningioma. We came through the same interparietal, precuneal, retrosplenial approach to get to this tumor. And this is one I did a few weeks ago. This is a recurrent tentorial meningioma that was treated by another surgeon that recurred, and it grew more anteriorly into the falcotentorial junction. You'll see that this tumor was squashing the top of the cerebellum and pushed it all the way down through the foramen magnum. So this patient had tonsillar herniation all the way down to C2, and she had a humongous syrinx in the cervical thoracic spine from this large tumor. You can see here, the straight sinus was actually violated. The tumor had eroded through the tentorium, through the straight sinus, and I came in from a supra interhemispheric approach combined with a infratentorial supracerebellar approach. This was done in the prone position this time, so I could get access to both corridors, and this ended up to be a beautiful approach. Look at the syrinx. This is the syrinx that was before from the acquired Chiari. You can see a huge syrinx with cervical thoracic spinal edema, and you can see a huge, this is post-op day 1 MRI. The syrinx is already immediately resolved. I cauterized the tonsils. I did a tonsillar resection here. This is the cautery artifact signal, and you can see a nice restoration of the cervical medullary junction CSF space. And these are our outcomes of these falcotentorial meningiomas. Again, the key is no venous complications. Preserve the veins, leave a little bit of tumor on the vein if you have to, but don't injure the veins. We can use this parieto-occipital transtentorial approach for a variety of other lesions. I really like this approach to the pineal area, especially if the tumor presents itself more posteriorly. I prefer this approach to the sitting position approach. You can see it's a nice access to the tentorial incisura, and you can get a complete removal here. I've also applied this approach to superior vermian AVMs. This is a lady who had a small vermian AVM with an acute rupture. You can see the rupture is right here in the superior vermis. Here's the blood signal. But this is a nice approach because you have direct access to the distal superior cerebellar artery feeders. You can cut the tentorium to get right on the top of the cerebellum, And here we've evacuated the hematoma cavity. I like doing these cases in the acute, subacute phase, meaning within around 1 week after the hemorrhage, if they're stable. I believe that the hemorrhage has already completed a lot of the dissection for you of the deep surfaces of the AVM. Again, venous preservation, intraoperative CSF drainage. These are all helpful tips to do that. This is another superior vermian AVM. This is a much larger one. This has a flow-related aneurysm here. She did not rupture, but had intermittent headaches and dizziness. Again, you can see a large complex AVM. This is the 3D reconstructed model of this AVM. You can see there's the large aneurysm. And if you treat the AVM, the aneurysm will disappear. This is a flow-related aneurysm. So here we're cutting the tentorium, cutting it just lateral to the straight sinus. So we map out the straight sinus, and then we're opening up the arachnoid. There is the anterior margin of the superior cerebellum. This patient had preoperative embolization prior to surgery. And so here the straight sinus is actually occluded. So we're able to cut the straight sinus here to get more exposure of the contralateral cerebellum. We'll do a resection ICG. You can see where the venous drainage was. And this had a nice preoperative embolization done by one of my colleagues. And so I was able to really do a bloodless dissection on this. This was a very beautiful approach, carefully dissecting around this AVM. And making sure we don't violate the superior cerebellar arteries. There's the draining vein. We've identified the draining vein. And once we divided it, we can now come around the remainder of the AVM. And there's the opening into the fourth ventricle. You can see there's the fourth ventricle opening. And then delivery of the AVM there. There's the final view. And then we'll do a little Surgicel in the resection cavity. And you could see the parietal lobe is barely touched. So there's the pre-op, there's the post-op angiogram, a complete curative removal of the AVM. And lastly, I show you this one. This is an unusual AVM. This is a lady who presented with episodes of these strange episodes of sleep paralysis. She had a scan that showed this large vascular lesion. It was a strange lesion in the sense that you could see there's a malformation here in the distal ACAs from the left injection, and it drains into this huge venous varix into the deep Galen system. But look at the external carotid injection. Look how huge these vessels are. These are all going through the dura, going into the falx, and then out this huge draining vein. So this case was shown to a lot of different endovascular experts around the world, and most of the opinions were that this was a dural AV fistula. Now, this is a critical teaching point here. It's very important to get the diagnosis correct, because if you had treated this as a dural AV fistula, the treatment is to go through the venous side, or you can go through the arterial side, but the goal is to occlude the venous outflow. I can tell you that if you had occluded the venous outflow, this patient would have had a massive rupture. And the reason why I know this is because during surgery, I had thought this would be a dural AV fistula. And when I put a clip on this draining vein to occlude the venous outflow, the AVM had swelled like immediately and started bleeding. And so I took the clip off right away. And at that point, I knew I was dealing with an AVM. So it's very important to know the diagnosis. This patient underwent multiple staged embolizations. You could see large feeders from both external carotid, feeders from both internal carotid and vertebral injections. And so after about 3 staged embolizations, we went ahead and resected this. And the approach I used here was an anterior interhemispheric approach, which you'll see here in a moment. So we're doing this through a anterior frontal craniotomy. The AVM and varix is mostly on the left side, so we'll do the left side down. Anteriors to the left of the screen, posteriors to the right of the screen. And as in a lot of these AVMs, the arachnoid is very thick from chronic inflammation. We'll dissect the arachnoid around the AVM. Here's the AVM. It's actually arising from the falx, and it presents itself to the subarachnoid space. There is no parenchymal component to this AVM, and we do stepwise devascularization. I identify all of the arterial feeders coming from the front, dividing each one after careful cauterization. And then we come around the lateral side, separating it from the frontal lobe with careful cautery. Then we come around the backside here, and there's the draining varix. There's the draining vein coming out of the backside of the AVM. And so when I had put a clip on it, this AVM started to swell immediately and bleed. So I took the clip off. And now I'm dividing the falx cerebri. Now, this falx was incredibly vascular. And you'll see here in a moment that I get into some arterial bleeding from the falx. And it's difficult to control the falx with a straight bipolar. I tried using clips, and it ended up making the bleeding more profuse. And I had a lot of difficulty getting this bleeding under control. So at this point, I called for the angled bipolars. And of course, it's going to take some time for the angled bipolars to come in. And so I packed this off with gel foam to buy some time and gain control. And so if you just plug it and hold pressure there, it'll stop bleeding. And another trick that you can do, which I ended up doing here, is adenosine arrest or adenosine pause. And this is where you ask the anesthesiologist to give adenosine, and it drops the heart rate and blood pressure, and the bleeding slows down enough so that your bipolar can have a chance to get control of the bleeding so it's not overwhelmed by the volume and pressure of the blood. And so once we got the angled bipolars, we did the adenosine pause. I was able to get this bleeding under control. And then resume the rest of the resection. So now we've cut the falx. Now I can get to the opposite side of the AVM. You can see the AVM presents itself to both sides of the falx. I can now dissect the arachnoid from the opposite side and then slowly cauterize the AVM, identifying the feeders that go into it. And of course, as you get towards the back, it's easy to get lost, and it's easy to get right into the vein of Galen complex. So it's important to be mindful of that so you don't get disoriented in this lateral position. And then we'll carefully put cottonoid patties to protect it. So we're now going to come around the backside, and we're going to take care of this draining vein. Now, before you take care of the draining vein, we're going to do a pinch test. So watch how the AVM swells again as I'm pinching this. So it means that there's still a lot of arterial flow going into the AVM. So we're going to work around the backside. There's still some feeders from the back of the falx. Here they are. These are a little bit easier to control because the angle matches the angle of the bipolar. And now we're able to get around it, devascularize the last portion of it. And so now when we do the pinch test, the AVM doesn't swell. So now it is safe to apply the clip to the draining vein. We're going to put a clip on the draining veins because it's such a large vein. And then we can go ahead and then divide it, disconnect the last component of the AVM. And then deliver the last component of the AVM here. And there's the final view. Complete resection, no ICG signal afterwards. Again, you can see the frontal lobes here are pristine. And postoperative angiogram showed no residual AVM. She was neuro intact, essentially. She did have a stroke from her first embolization, a minor one, but improved with time. So, in conclusion, these interhemispheric approaches can be safely navigated to reach these deep targets of the brain through these natural corridors that we can expand through CSF drainage, opening the corridors of the falx and tentorium. And the endoscope is a beautiful tool to get a look around view. And again, it's very important to preserve these veins and to have gentle handling of these tissues to achieve success. So I'm excited to announce I'll be working with John again. We're going to resume the Art of Brain Surgery Masterclass series. And here's my new affiliation contact information. Thank you again for your time.
Thank you, Professor. Thank you so much for your inspiring presentation. Your demonstration of a neuroanatomy-based clean and precise neurosurgery is truly impressive and provides invaluable insight for all of us. Thank you.
Thank you.
Okay, Harshad, do you have a comment or question?
Hi, James.
Hello.
Hi. Superb demonstration as always. It is always a treat to watch you doing these cases. Of course, all are virtual. Love to see you in real also. And superb demonstration you have shown on interhemispheric approaches. When you do a contralateral approach, coming from the front to the posterior third ventricular region, do you have to go through the falx or you just able to reach there without much problem?
Yeah, so if it's a posterior third ventricle, you don't have to cut the falx. The
Yeah,
only time you need to cut the falx is if the lesion occupies both left and right lateral ventricles, or if it's a falcotentorial type lesion that extends across the midline, where opening the falx gives you the access to the opposite side. But for the third ventricle, your corridor is between the fornices, so you don't need to cut the falx to get to that.
nice. Velum interpositum meningiomas, especially that recurrent one. Do you think that this kind of a cases you would like to do Stein's approach or go from the top?
Yeah, I've done the sitting approach in a lot of cases. I've transitioned to using the interparietal approach in the lateral position. I just feel that it's safer in the sense of avoiding air embolism that you can get in the sitting position. And I feel that there's a lot of advantage in that it's more comfortable for me from a surgeon's ergonomics perspective, but I have excellent control of the superior pole of the tumor, and I can see the inferior pole of the tumor, and I can get beautiful view into the third ventricle. So it's an approach that I've largely adopted over the Stein's approach that you mentioned.
Very
What,
good.
what makes
Go
you
ahead, go ahead.
decide whether to go infratentorial or supratentorial, especially in a pineal tumor?
Yeah, I mean, there's a lot of different nuances. I think I look at the position of the veins. I look at how far is it from the cerebellar margin, how much of it is actually in the third ventricle, in the posterior third ventricle. And these lesions, they're not purely in one location. Some of them present a little bit more posterior, in which I think a posterior approach is more easy to do, and some of them extend more anteriorly, in which I think an anterior transcallosal is an easier approach to do. So, like that metastatic tumor I showed, it presented, very anteriorly, and coming from a sitting position approach would have been very difficult, in my opinion.
Right. A wonderful technique. One more point to be noted. Your videos are all bloodless. At all.
Yeah,
Or no any blood.
as Dr. Fukushima taught me years ago, red blood cells should remain in the blood vessel.
Correct.
That's
Very well said. Very well said.
idea.
Wonderful, wonderful, James. Super.
Okay, I
you.
believe
Thank you.
Ibrahima, you have a question? Just unmute, please.
Yes, John, thank you. Thank you for Professor James for this wonderful presentation. I really enjoyed this presentation today. Actually, I had like recently a very hard case like that on a child. I just have like one question for Professor James. In this case, like usually, do you have like some critical condition with this patient when you have like surgery, and did you have any issues with the anesthesis? Sometime because recently I did one case with the child. So the patient stay like long hours on surgery. I could not remove the tumor all of it because the tumor was so, the blood supply was too much. So I could not control all the bleeding, and the patient lost a lot of blood. We could not replace that much quickly. So we will try to stop the surgery on a way to preserve like the patient life. So actually the patient wake up well and without no further complication. But instead of that, what did you advise for this kind of situation with the anesthesis and with your surgery?
Yeah, you make a great point. Especially if you're working with children, right? Depending on the age and the weight of the child. Obviously, a smaller child, hypervascular lesion is a lot more treacherous because you cannot afford to lose much of any of the patient's blood volume in a smaller child, right? So, in contradistinction to adults. So I think you did the right thing to abort, and the saying of, you can always come back and fight another day. Don't lose the patient on the table. So sometimes you have to stop. Sometimes in a vascular tumor that's bleeding, you have to do what's safe and stop and come back and fight another day. Sometimes, it gives, hopefully you have pathology to determine what type of tumor you're working with. Maybe the tumor can be amenable and sensitive to, chemo radiation options if it's a germanomatous type of tumor. But maybe you need to consider, if it's vascular, to do an angiogram to see what's the blood supply, and if needed, can some of it be embolized to help your surgery? And maybe you can think about, other alternative approaches to get to it.
Okay, thank you, Professor. And actually, that is quite a good decision I just made for that patient. But the fact is, actually in my country, we don't have like any possibility to have the frozen section pathology directly. Mostly like the pathology result, which came out after like 3 weeks or 4 weeks, usually. So in terms of that situation, I still have like to wait until I get the result. From that, I can see if there any possibility to take it back for the surgery. And the other side about this situation is like, what did you recommend for some beginner in terms of having like that kind of big patient in terms of evolution or progress of surgery? Because like me, I would like to say, okay, this is what is my plan for the surgery. So mostly when you have surgery on your table, the anesthetist is over here telling you, oh, we don't have to wait for long hours of surgery. So it's quite difficult because I don't used to have that in my center where I was trained. So here, that is my very big issues from now when I'm having like tumor surgery.
Yeah, I mean those are challenges that can be real. Certainly developing a type of chemistry with your anesthesia team is very helpful so that they get used to your, your rhythm, your cadences, your style, and a good thorough discussion ahead of time on the anesthetic surgical considerations is helpful. And I think as having, for the young surgeons starting out, I think having mentorship is also very important, whether it be, direct physical, like local mentorship, like somebody in your department who can help you with these difficult cases, or, nowadays, sometimes remotely, getting advice from other colleagues around the world, I think is also very helpful.
Thank you so much, Professor James. It was really great presentation. We really enjoyed it. Thank you so much.
Thank you.
James, you have moved somewhere else from the Rutgers?
No, I'm still in New Jersey. I practice primarily at Cooperman Barnabas Medical Center. But I'm part of an organization called the Neurosurgeons of New Jersey, where we're building a skull-based institute of New Jersey. So I'm basically where I am. I'm in the same hospital, same location.
Right. Hope to
Right.
see you some one day.
Yeah.
Yeah, great. We'll have to work out, James, when we're gonna do. That's great. You're doing the series, and hopefully we'll build an audience. Thank you very much, everyone, for coming. Harshad, Ibrahima. Sometimes these small groups are really good for personal attention, for teaching reasons. So I'm glad you came. Now, I just want to tell you about what we have coming up in like an hour. We have a webcast with John Adler, the ex-chairman of neurosurgery at Stanford, is going to talk about the ZapX. It's not new, but it's a radiosurgical technique as well as CyberKnife. John invented. So he's done a lot of work in this field. So he's going to be here at 10:30 Eastern time, and you're welcome to come there. And otherwise, just listen to when James starts his series. And Mohammed, thank you very much for stepping in.
Welcome, John.
Okay, we'll
Thank
see
you.
James,
you.
looking forward for some schwannomas.
I'm sorry?
James
Yes.
is, yeah, looking forward for some schwannoma lecture.
Okay.
Oh, is that going to be in the series? Possibly.
Yes,
Maybe.
yes, please.
Oh, great.
He is wonderful
Okay.
in various techniques.
Okay, we'll see you at Adler's talk. Thank you.
All right. Thank you, John.
Thanks, Mohammed.
Bye, John. Thank you.